today in a clinical practice. That mitral valve is leaking. We do not know how to tackle with that mitral valve. Should we go for repair or we replace it? And for that, we have a first experience from none other than Dr. Naman Shastri, who has traveled all the way from Ahmedabad to present his presentation over here. And may I request the chairpersons, Dr. Sandeep Mishra can be on the dais, please. Dr. Atul Gupta and Dr. Rajat Mohan can be please on the dais. And I'll request Dr. Louis Badano, if in case you have some suggestion and comments, please do share your.
So I think very interesting and exciting area, and we will not come in between. And let him have his presentation, and then I think we can discuss.
Good evening, everyone. It's an honor for me to be a part of this event. I thanks Dr. Gupta sir for kind invitations to talk on perioperative mitral valve repair versus replacements. I was supposed to talk a little late evening, but suddenly I realized that the last batchman is asked to come in the first down. So thank you very much again. When we talk about the mitral valve, and we always see that when we talk about intraoperative period, we can't just talk about the leaflets. We have to talk about the leaflets, annulus, we have to talk about the papillary muscles, cords, left ventricle, left atrium. So everything when we talk about and the interpreting the mitral valve pathologies, we always look about the complete mitral valve structures rather than just leaflets. And for looking that, we have to understand that before jumping to the 3D, it is very important that we should have the best 2D images. Unless and until we have the very good 2D images, we cannot acquire a good 3D images for that. So principal thing is we should be very much good into the taking a good 2D image, and once you acquire good image, then only you should jump to the 3D images. Now, to acquire the three-dimensional echocardiography in perioperative period for the mitral valve from 0 to 120 degree, when we take three dimensions without three-dimensional zoom mode, without color mode, that gets us to the what is so-called the surgeon's view, or what something called as an NFS view. On NFS view, we have a pointer. So on surgeon's NFS view, what is seen here? It's okay. So on the left side, you can see there the mitral valve has been segmentized according to the scallop it has on the posterior mitral leaflets. They have the two scallops which has produces P1, P2, P3, and reciprocal to that on the anterior mitral leaflets it is A1, A2, A3 from the left to right. So anterolateral to the posterior medial. So from left to right, that is from the A1, A2, A3 on anterior mitral leaflets, and P1, P2, P3 and into the posterior mitral leaflets. And the sweet and beauty part of the three-dimensional is that we can see that both of you from the LA, we can see the both the things from the LA as well as from the left ventricle. So all the segmentation, which is very important to discuss with the surgeons, whether he has to tackle with the segments or not, he has to be explained correctly that whether the A1 is involved, A3 is involved, which commissary is involved. So for that segmentation, this is the best way of dealing with. Otherwise, on 2D assessments, we have to go all the way to all the 7 important standard views which is assessed for the mitral valve. And for that, we have to just keep a judgment that it is rather A2 involved or P2 involved, and which area is ruptured, it is very difficult. So we have to go all these 7 segments before coming to the diagnosis. But if you look at the just live 3D, this is a live 3D view. In that we can see that this is the 5-chamber view where you can see that entire anterior mitral leaflet and posterior mitral leaflet is seen here. So from anterior to posterior we can go through A1, A2, A3 and P1, P2, P3, and here it is excellent seen that in the bicommissural view, A2 is sandwiching between the entire posterior mitral leaflet, that is P1 and P3. So even here on the 2-chamber view, you can see this is the LA appendage. So entire anterior mitral leaflet is seen here. So when you put a live 3D also, you can exactly segmentize which view you are targeting. Even in the transgastric short axis view, from the basal mitral view to the submitral apparatus, everything can be nicely explained to the surgeons that whether what is a caudal line, whether there is a fused cords or not. Now, when we talk about the repair, we always deal with the MR and MS, and Carpentier's has given a very nice functional classification on the basis of the leaflet motions, and this classification is helping surgeons to understand that what repair he is doing and what pathophysiology lies with the patient with the mitral regurgitations. So when patient is type 1 disease, it is normal leaflet movement because of the purely annular dilatation. So this patient usually can have the other pathologies like aortic regurgitations or atrial fibrillations. But when we talk about the type 2 pathologies, it is a hyperdynamic leaflets. That could be because of the cord ruptures, elongation of cords, or the degenerative mitral valve disease. When we talk about the type 3, it is a restrictive leaflets in the both phases that usually particularly happen in type 3A is a rheumatic disease, other type 3B is a ischemic heart disease. So by looking at the leaflet movement only, we can diagnose which problem, what problem lies it. But before again jumping to the perioperative, the preoperative investigation is very important because under anesthesia it produces unloading conditions. In unloading condition, quantifications of the mitral regurgitations is very difficult. So preoperative assessment of a disease is very important. Like in this case, we call it as a type 2 because of significant hyperdynamic leaflets. So in perioperative, we look at the height of leaflets, annulus, coaptations length. We look at the C-septal distance in a degenerative disease as well as the other chambers. So we never should neglect the other chambers like LV. So if we start with the myxomatous Barlow's disease, it is like the disease where all the segments and both leaflets are involved. This is a typical format of the Barlow's disease where not one segment but both leaflets are involved. That is called bileaflet prolapse. And this usually happens in a younger age group, but they present very late because of the thick cords and the thick papillary muscles and thick leaflet tissues. So they can rupture very late. So this patient hardly comes with a cord rupture, but when they present with a huge LA and left ventricle. On the contrary, degenerative mitral valve disease, where they have the fibroelastic deficiency, where they have the only one or two segments involved, they have the thin cords, thin leaflets, so they present quite early in a period. So they have the smaller annulus as compared to the degenerative disease, which is myxomatous, which comes quite later, having the bigger annulus. So these patients are still very easy to manage on repair, but in the degenerative disease, because of the myxomatous, it takes a lot of good skill before operating. Like suppose this is a case of degenerative valve disease on perioperative period. You can see in all the view, it is very difficult exactly to locate where the disease lies. So we have gone through all the different lists, but once you put this patient on the three dimensional and face view, you can see exactly that P2, P3 area is a flail and the cord is ruptured. And when we look at this patient in intraoperative period, it exactly correlates where the disease lies. So the end phase view exactly correlate very well, and in the fibroelastic disease, we can correlate very well. But in rheumatic heart disease, still there are surgeons who manage to do the repair by open mitral commissurotomies. They put a ring or they cut the cords, they replace the cords, but in that it is very important to assess both leaflets, whether they are calcified, what is the status of commissures. When we talk about the ischemic, and this is the last and important aspect in ischemic mitral valve disease, usually we find the normal leaflets, but important aspect is when we look at the cords, the posterior mitral leaflets is tethered in ischemic mitral valve disease, and this is what the biggest difference of a left ventricle geometry as compared to the other diseases. Now coming to the business of how to differentiate repair versus replacements. Very nice article published in the European Heart Journal suggested the probability of successful repair in the organic MR based on the echo findings. And if you look at the degenerative valve disease, when the patient has a localized prolapse, only the one or two segments with the non-calcific lesions or non-calcific annulus, the feasibility is repair is very good. Like in this case, there is only A2, A3 part involved, and these leaflets are very easy to deal with for the repair as compared to other replacement. Otherwise, if they have the more than 3 segments involved in these conditions, then we can always discuss with the surgeon that they should go for the replacement rather than repair because they do not have enough tissues to deal with. So this one segment involvement is a very important thing. Like in this case, and that is like here you can see that the anterior mitral leaflets, we are not very much sure. In posterior mitral, we can say, yeah, this is a PML, some cord rupture is there and there's a flail leaflets. But what about the anterior mitral leaflets? But when we did the 3D, we could find that only posterior mitral leaflet has a cord which is ruptured and lead to flail. and then we can say that okay, that he has to deal with only one segments of the posterior mitral leaflets, that what they did with the quadrangular resections and the ring annuloplasty, that is the reduction size of the annulus, and then patient did well after the surgery. Rather, in case of the Barlow's disease, as we know, it's a bileaflet prolapse with the extensive more than 3 scallops. So usually Barlow's disease, they have the more than 3 scallops, but if the posterior commissure is involved, then still the chances of the repair is okay, though it is difficult, but can be done with the skillful surgeons. But if it is the anterior commissure is involved, so if it is a posterior commissure involved, it is difficult but still possible. But if it is severely Barlow disease but anterior commissure involved, then the repair is difficult, and that we can see on the perioperative period. Like here you can see that only there is a jet coming for the posterior commissures, so still this is manageable. But look at the downward images. All these images say the severely bileaflet disease with little significant thicken of a leaflets, with the both commissures are involved, and we can always deal with the surgeon that if they want to do it, they have to deal with the lot of resections, and sometimes they may need to add 1 or 2 more cords to keep the both leaflets down to the annulus. So these are the very difficult repair. Now these are the case, like here you can see then the top from, this is again a Barlow's myxomatous disease, but what is seen here, it was always a dilemma on the 2D that what is seen, whether it's a cord ruptures or something vegetation or that. But when we look at the 3D, we found that there is nothing, like it is just a discoordinating movement of the whole entire leaflets. So in below part you are seeing the proximal part of leaflets, and distance we are seeing the distal part of a leaflet that can be seen that there was no cord ruptures or vegetation. So this is how you can differentiate with the 3D and say surgeons that okay, they need to repair this, and they may not go for the replacement. Now for the rheumatic heart disease, in rheumatic heart disease, as like the Barlow's disease, if they have the little calcific lesion, but if the pliable anterior leaflets, then the repair is still possible. But if they have the significantly calcific anterior mitral leaflet, then they should not go for the repair, but they should subject them for the replacements. So like here, this is called a lung and Cormier score for suggesting whether they should go for the interventions or not. Like here in this case, you can see that what they have shown that if they have the non-calcific anterior mitral leaflets and adequate size of the length of the cords, if the cords are about 10 millimeter long and the anterior mitral leaflets are spare, still surgeons can do the chordal separations. They can still put a mitral ring, and if required, commissurotomy, and they can go easily get out without any problems. But if they have a significant calcific both mitral leaflets and there's a significant restriction of movement, then we can say surgeon that okay, this is very difficult, then he can go straight away for the replacement. This is the lung and Cormier score, and if they say the group 1 or group 2, this patient can go for the open mitral valvotomy. Now in this case, this is the today's morning's case by itself, that we found this patient with the significantly proximal cord. So on 3D examinations, if you have the proximal cord which is fused involved, see the cords fusion starts from the papillary muscle, they just migrate towards the leaflets. So when they have the proximal cord also involved with the fusions and the length of the cords are significantly reduced, then we can say that these patients, the cord separations even are difficult. Now these are the very difficult mitral leaflets where you can say significantly calcified leaflets, both leaflets are restricted, and always surgeons should never think of doing it, even though they do delaminating of a leaflets, it is not possible. And in this case, we can even ask surgeon that if you are doing replacement, please explain relative that these patients can require pacemaker because of the significant calcific aortomitral continuity. So this is how it can differentiate. Now the endocarditis, and that's the important aspects. Now in endocarditis, if it is prolapse but destructive lesions, then one should not go for the repair, but they should go for the replacements. Like in this case, like you can see that this is an anterior mitral leaflet which is totally destructed. Now this patient was referred to us in a suspicious of SAM. So they say that patient has a SAM, please look into it. We did the 3DT pre-operatively, and what we found is, in fact, it is the anterior mitral vegetation which is just moving into the left ventricle. This is the ascending aorta part where we can see that the vegetation is hanging around. So then we thought it is in fact vegetation, and total anterior mitral leaf fluid was totally distracted, and these patients, without thinking about the repair, had to go for the replacement. But if you have the only one single segment of a leaflet having the vegetations. Now, the another beauty of 3D is it differentiates whether cord rupture or the vegetations. It is very nicely differentiate these two aspects, that here it is seen that it is P1, P2 part, there is a vegetations. We just remove that part and we can do the annuloplasty ring and we can get away without any MR. So this is how it is very important to differentiate. Even in this one case, we had the patients with the A2 cleft. The third important aspect about the 3D is it can nicely differentiate the difference between the cleft and the scallop. So if the separation is up to the 50% of the leaflet in between these two segments, then we can say it's a scallop. But if it is extend up to the more than 50% up till the level of the base of annulus, we can say that it is a cleft. So this is how it differentiate. I'll just take only 1 or 2 minutes more about a very nice case. Like we had a very nice case of the degenerative valve disease. Intraoperatively, we find something hanging on the below of the anterior mitral leaflets. We were not sure what it is. Color flow showing severe MR. Now on this view, again it is very important, so that you can see something just coming up and down in the just back of. See, this is P1, A2, and P3 on the on the 2D view. But you can see something just going up and down. So when you say some part of the mitral valve which is going up and down in the back of A2, means it is P2 prolapse. So when patient has P2 prolapse, you always see some second image behind the A2, and we can say that this patient could have the P2 prolapse. And all these view did not clear us exactly what we are supposed to do here and what is this part which is hanging. On 3-dimensional examination, we could not find any vegetation, calcific part, any cord, something which was hanging. But what it was found, it was just part of a cord which was proximal part of a cord which was calcified, and otherwise there was no significant cord rupture. But it was part of the P2 which was a prolapse, and that was giving it. But rest of the leaflets the surgeon found, and even intraoperative we found with the T that it was could be repairable. Even from the apex view, we could see from the left ventricle, except the P2 part, rest of the coaptations were looking good. There was no cord ruptures and all. And post procedures, we had almost nearly the nil mitral regurgitations for these patients, because we could tell them pre-operatively that this patient does not require any cord elongation, does not require any more things to be done with the cords or papillary muscle, just do the annuloplasty ring, because it is only the annulus which was 46 millimeter needs to be reduced, what they call it, the remodeling annuloplasty, and then after surgery patient had fantastic result. So here you can, even in the post-operative, you can see very nice the part of a leaflet which is moving, both leaflets are moving. Here on the 3D view you can assess the post-operative sham or not, the leaflet is moving in LVOT or not. You can see very nice AML and PML are just touching out. So the repair and replacement decision can nicely be taken very easily intraoperatively these patients without any problems. And if we have the more exercise been done on the 3D echocardiography, it will be really a boom to the help to the surgeons, where before scrubbing in and going in, they exactly know what they are supposed to do. Second thing is, with the 3D images, they do not have to understand different categories of the different images of 2D. On end face view, they exactly dealt with the diagnosis and what they are supposed to be there. So 3D assessment is very useful, which gives additional informations over and above the 2D, which is still an important base. And I said again that before acquiring the 3D images, it is very important to have the best 2D images. Without that, it is not possible. Thank you very much for that.
Well, thank you, Dr. Sastry. I think so. It was an excellent presentation, and what I remember was that when 3D started off, mitral valve was the most important reason for 3D echo, and particularly on the mitral valve only. that whenever the surgeon used to decide upon that person has to undergo a replacement or the repair, he used to come and see the 2D images, and then at the end of that day he used to say that, okay, when I go inside I decide that it has to be a repair or a replacement. But I think so with the coming up of 3D and better images, newer systems which have very crisp images, I think so it can be preempted that surgeon before going in, he can decide that we should have a 3D, we should have a repair or a replacement. It was indeed an excellent presentation. And any questions from the audience, please?
I think Dr. Shastri, it was a brilliant presentation. Very nice. The way you mentioned about the Barlow's disease, everything was so beautifully done. I remember I met Pavlov when I was working with Naveen Sinanda in his lab, who wrote a book on mitral valve prolapse. But I never seen a picture like this, the way you showed it, so beautifully. And I think everything can be told to the surgeon, whether the calcification of commissure is there or not. He can do in repair or replacement, and even the prognostication can be done so beautifully. I think it was a very outstanding presentation, which is that we need to learn. And I think I'm sure a time will come, we will believe in 3D more. But of course, I agree with you that the 2D pictures are very important to understand the 3D, and we all should focus on 2D, but keep in mind that ultimately we have to give better information to the surgeon for a better outcome of the patient. Thank you.
Dr. Shastri, excellent presentation. Would it be fair to say that in majority of the patients who you plan to send for repair, 3D echo is now the gold standard? I mean, is it that 2D is just the base for and no surgery or mitral valve repair should be planned without undergoing a baseline 3D echo?
See, very good question, sir. Actually, it is not that every operation theater has 3D. Still, many centers are doing with a 2D only, with an assumption that what could be the pathology. But if we have the 3D toppings on our routine practice, then definitely before getting into the surgery, they have exactly idea what they are supposed to do. Like in one of the case, when they thought it could be the SAM or what, but when we say that it is in fact a vegetation of anterior leaflet which is just going into the LVOT. In another case, what we which I have not explained, that it was referred to us as like cord rupture, but when we realize it, that it is in fact a vegetation, not the cord rupture actually. So this is how they know exactly before getting into the surgery, then exactly they know, and what need to be explained to the relative. Like if you have a significant aortomitral calcifications, and we can say that this is very bad left aortic wall, and while doing it or accessing, they may have end up into the touching the nodes. So they can always explain to the relatives that this patient may need aortic wall replacements after the surgery. I mean pacemaker implantations after the surgery. So definitely, if the 3D echocardiography is there, surgeon becomes totally dependent upon that. So now surgeon asks for the 3D images rather than the anesthesiologists give them. So they always have a 3D machine.
No, what I'm saying is that there are very few surgeons who do repair actually, as a matter of fact.
Right.
At least in this country and even everywhere. So there are few places where you really require this.
True.
So for doing a replacement, probably it is not that essential. But if you plan a repair, there are few surgeons only. At least on those labs, I think. We
Yes.
could have
Definitely.
because there are so many parameters which could be known even before the
Absolutely.
surgery.
Absolutely.
The second thing I wanted to ask you is that 3D printing is going to be the future of medical devices, and for TAVR also, and for everything you'll probably have a 3D printed device. So will this 3D echo information be translatable into 3D printing thing? Is there something going on? Because I think at the moment we are looking at some other technologies to 3D print, but you think it is the future?
You want to comment on this?
Wanted to say something?
Yes, I think that this is definitely the way. Now we cannot only print with resin ink, but we can print with a material that really resemble the leaflets structure. So this is not just to look for teaching purposes, for communication to the patients, but it also a way for the young surgeons in training to perform the procedures. So this is one of the major, the added values.
3D printing is going to be future of medical device everywhere. So I think this is something which I think next decade or next 10 years we will be talking of 3D printed devices.
Actually, 3D printing has a issue because you need very stenciled borders. So CT scan probably at this point of time is the thing which gives you the best stenciled border, carved out. And that's the reason why 3D echo is going to be a little while away, but it is going to be at some point
What
of
I'm
time.
saying
But
is in
CT
future. In
correct,
future.
correct, correct. They have to have more faster frame rates, they have to have better
it will happen.
resolutions.
I mean, over a period of time it will happen. So we know that. Dr. Dev, you wanted to say something?
I think it was a remarkable presentation. But the landscape is transforming with a lot of new mitral therapies which are going to be, I mean, the gold standard is going away from surgery, and there's a lot of optimism with transcatheter techniques. So I guess with time we will have more integrative solutions where we may be able to think that, okay, this is a case for a tendine and this is a case which can clip, or what we can do. And we know the mitral valve is a complex structure, so maybe combination of therapies would evolve.
Exactly, you're right. So for example, at the moment we have, CT getting integrated with Cine.
So Sameer's point is completely valid, but I think with 3D image echo and in combination with the CT, you would have much more database that you can make a 3D print out of, if at all.
Yeah, and at some remote future, possibly.
But this is really science
3D
fiction still. I
echo
mean,
will
we
be-
know it is going to happen, but as far as practically is concerned, they can possibly look at it because they have access to cutting edge technology. But we don't.
No, I think so.
Okay,
that-
friends, let's move on to the next topic. Thank you very much for chairpersons. Kind excludes can